Hello, everyone. My name is Aswin Panda, and along with my fellow student associates Joycey Brass and Rohit Conradi, we've been working with Dr. Leanne Field's team on closing adult and prenatal immunization gaps. With the training we've gone through from the Texas Health Catalyst program, our role as student associates was to assist our project team in refining their business model as well as focus on their path to market. Working with our mentors, Amy Altman and Kelly Hawthorne, has truly been an impactful experience, where we learned how to turn an innovative strategy into a support system that can save not only millions of dollars, but millions of lives as well. We are passionate about supporting our healthcare providers, and working with this team has shown us how an efficient and organized support system can make their lives so much easier. Our project team has a successful proof of concept and is looking to expand the CDC's code list. I'll now hand off the mic to Phil Beckett to explain more about their innovative support system.
Thank you. I'm Phil Beckett, and I want to thank both our team and our advisors. But chronic diseases are the leading cause of infections, death, and healthcare costs in the United States. 60% of adults have at least one chronic disease. Vaccinations are a potential way to reduce that risk and reduce healthcare costs, but they have to be delivered precisely. We believe that targeting that 60% of 200 million adults in the US at $1 per life gives us $120 million revenue to administer the VAC-OPT product. But for healthcare, it's worth billions of dollars in potential savings. The problem is healthcare providers have difficulty identifying which patients need vaccines. The CDC rules are complicated. Their electronic health records just go on age and past immunization history, not contraindications or comorbidities. So what did we do? We did two things. One, we took the CDC rules, we took from 104 medical codes to 8,000 for vaccines. We ran these against patient medical records, and we identified 100% of patients who could use a vaccine. The CDC current list only identified 18%, so it missed over 80% of those. The second thing that we did was integrate this workflow into the provider's electronic health record so that it was easy, part of their workflow, to see this is what we recommend for this patient, boom, problem solved. We piloted this at People's Clinic in Austin. The medical director, Dr. Appel, said, getting an accurate alert that a patient needs a particular vaccine can be challenging. VAC-OPT provided much more useful guidance, saving time, reducing missed opportunities to give adult vaccines. Our team is multi-discipline with academics, pharmacists, physicians, technologists, and health information experts enabled to put together this holistic solution. We got great feedback from our reviewers. One was clinical impact. We've integrated this seamlessly because if it isn't used, it doesn't have any impact. We've also implemented an electronic health record agnostic, but it's expensive to integrate to electronic health records. We can deploy this across easily without any integration, or very lightweight. And we're also leveraging the health information ecosystem that exists across the whole country to deploy this. So we can do it very quickly without costs and leveraging existing. Our path to market is currently applying for funds. Over the next 18 months, develop and implement the VAC-OPT system and put in 4 clinics and 2 pharmacies, and by 30 months, commercialize our product. The ask from Texas Health Catalyst, the funds, is to help us finish off, expand to all adult vaccines, put together a viewer, and seek additional funding. And with that, thank you.
Thanks, Phil. Any questions?
Thank you. Great presentation and definitely a worthwhile effort. One question that I have is, I'm assuming you all did a pilot at People's Community Clinic. Just curious about the efficacy of the system, and the way that I would measure it is, what % of time when that alert pops up do physicians recommend to their patients? And 2, like, what % of times do those patients accept those recommendations? So just curious about those outcomes.
Yeah, no, great questions. And we did work really hard. You know, part of that's accepting. We worked a lot with People's Clinics. That's why we want to do a bigger pilot and really measure some of those outcomes, because we spend a lot of time with this one getting feedback on, hey, we don't like this, or can you move this here, or we don't understand. you know, to get trust, you've got to build a lot of transparency into the system. So working with physicians, we got a lot of really good feedback. If it's giving recommendations, then why? So we feel we're in a good place now to go into a pilot and do that. In terms of patients accepting, you know, there's we're not necessarily going to change. You know, we're just really providing evidence, but we've got tools to measure that. So in this codes in the electronic health record, where again, in our second study, we can go and say, we offered it, but did the patient accept it or reject it, and compare to old data. So I think we can get to those numbers. But thank you.
That was great. That was a great presentation. Thank you. A little question on the customers. Have you guys identified who is going to actually pay for the technology or the product, and what does that pathway look like?
Yeah, our thoughts, the main ones who benefit from this are the health plans. You know, there's the ones paying for healthcare. If you reduce complications and expensive down the road, it's sort of long term. You don't see the benefits for a while, but really looking at the health plans, paying a very low fee for this. They were used to a per member per month, adding it to their fee, then deploying it, because rather than the physician's office, you know, they're taking care of the patients. They're not really getting the direct benefit of it. So that's where we're looking for the business model.
Great, thank you.